It's titled What's in a Name? A Fleshy Tale of Diverse Pathologies, replied the callus. Callus we know is a Latin word which translates to flesh and hence the title. And we should soon discover as to why it is a seed for diverse or a method of pathologies. Sunday evenings can be spent in cozy environments at home where we are all comfortable. You can just walk in the eye, be happy about it. Only to be very realistic of a Sunday night that Monday morning is going to show up on Monday blue. And what if in the OPD, when we are the patient and the pink becomes the new blue? And then we see something like this where a pathologist has arisen from the inner canthus or the medial angle of the eye and has been rendered a stepmotherly treatment to the eye, while you can see a very well centered IOL through a round pupil and failure to notice and recognize as to how a pathology can arise from the canthus. So we decided to introspect and then retrospect our own case records over the last 2 decades at Zeta site, and we found 36 eyes of 34 patients, and we included all those patients who underwent a biopsy and histologically removed any arising from the cannular mass. What it involved was a comprehensive clinical evaluation with both attention to detail, one slit lamp to the eye, and also system evaluation, surgical excision of all those masses which are well circumscribed and amenable to surgery, followed by histopathological analysis. Surgical excision, we kept in mind the oncological principles that 4 mm flare margin was taken from the given lesion associated with or without cryotherapy, the pyogenic conjunctiva, and surface reconstruction either with glue or amniotic membrane graft as indicated. So this is a representative diagram of how a 4 mm margin from the lesion would look like. And our results showed that there was a higher preponderance among the males, with unilaterality being in about 95% of our patients, and majority of them presented with a mass. Also, we realized, we inspected, examined the punctum and the lateral nerve flow pathway to rule out any association with the lateral outflow system. And Epipora was a presenting symptom in about 30% of our cases, with majority of them on definitive histopathological diagnosis were proven to be benign, while a few of them were malignant. This is the range of lesions our record showed to us, ranging from congenital abnormalities like a complex stoma, inflammation, cystic lesion, benign lesions like papilloma, and we shall come back to this case, which I shall show later, a combination of OSS and amyloid, which is absolutely rare, and also those leaning towards the side of malignancy involving sebaceous adenoma and sebaceous gland carcinoma and lymphoma. This on histopathological diagnosis were proven to be arising from canicle, and each of these pathologies are listed as seen. This is the corresponding histopathological image to each of those cross images seen. On tabulating all our results and subsequently comparing this with other present large series, where it was shown that papilloma and nevus were the most common in the other series, to our surprise in our oncological setup, we found that sebaceous gland hyperplasia was on a higher level. This is a few comparative images of pre and post-operative cases at 6 weeks and 3 months. What is interesting to note in among 2 of these cases was this case, a combination of both an OSS and an amyloid, and systemically we evaluated this patient for amyloid, which is negative. This is a histopathological confirmation with the apple-green birefringence on bipolar microscopy. This was a particular case where we started off with a cancer where there was a fleshy mass at the medial angle of the eye, or lymphoma, on histopathological diagnosis. And systemically, the patient had evidence of lymphoma on PET-CT examination. Thus, in conclusion, slit lamp evaluation is the key. Not every mass at the inner angle is lateral. 80% of the cannular masses are benign, and it is a doorway for system report. In
those suspicious lesions, did you include the incision?
No, sir. These really were well circumscribed and unable to complete excision biopsy. So we did a excision biopsy in this case.
And if you say 4 millimeter of circumference, so you would be disrupting the lateral drainage system. Anyways, you have to do it.
Yes, since most of these only in cases of malignancy there is suspect that it can be a malignancy going there with a clear margin. However, for the benign lesions that is not followed.
That's what I'm saying. So that means where you suspected, you first did incisional biopsy.
The suspect is we rendered clinical radiographical work of more than an incision biopsy. Like for example, if I'm doing the research which is my first, and I'm also looking at the examination of a nodularity which is extending beyond the tarsus can be focus. Or if I'm looking at the limb margin, I'm looking at widening or thickening of the limb margin, loss of lashes, or other signs of disease.
Lots of flashes are not going to be there because
In
the
the
patient is
apart from being an accelerated lesion of the canopy, where it is necessary and this very rare. In our case, we had that one case where we might have also and then subsequent reconstruction of surface.
in that particular case, did you then excise the canalicular system as well?
Not, yes, sir.
Are you sure?
Yes, sir.
Because I would probably not excise the canalicular system in the first place. Keep the patient over in the follow-up and the size, definitely size as much as possible clear margin excision, but sparing the canalculus because the canalculus is not overtly involved and it's a conductible thing and canalculus are anyway deep. If you draw a circle 4 millimeter, with a sort of a radius of 4 millimeter all around, definitely you will have it.
Yes. Yes.
What is the
I would rather
So for a sebaceous adenoma, like what he's trying to say, sebaceous adenoma versus a sebaceous gland carcinoma, many a times clinically we can't differentiate. So in such a case, you can't just go ahead and go wide excision biopsy. Yes, you can do an excision, in toto excision rather than doing a incision biopsy because the mass itself is so small. But following that, based on the histopathology, you need to take a call whether you need to go in a second time and do the wide excision biopsy.
Yes.
But if you directly go ahead, maybe this is sebaceous adenoma and you have done everything like the retinal system is affected. That is not a scenario we would
Yes.
like to have. So
Yes.
that's what we said.
Yes. Yes.
I think they probably do frozen section
Control. That's
control.
Yes.
I don't think for these
The inner suspected.
I would doubt any of these lesions have gone for
Not for these cases. No, not for these cases.
So
The net involved cases, yes.
how long was the study?
20 years.
Which center?
Center and both institute with Dr.
And
Mohammed.
because center of is not a contact study.
Yes, sir. 10 years back, yes. Since all these cases are Dr. Mohammed.
Thank you so much.